strengthening community health systems with including a gender and equity lens. So really just coming to bring in that perspective and also learn from others in terms of what gender programming and how gender affects health systems. In society, the expectation is that the men are the breadwinners. So if they're the ones who are bringing the money and the job is paid, then they should be given the first chance to get the money. So if it's free, then it's the woman, because in the first place she's not expected to work, or she's expected to survive somehow, maybe go to the garden, do something small. But if there's a salary to be paid, then in most cases in our society, it's the men who are looked at as the breadwinners, so they'll be given that priority of getting the job. It's been exciting to see what has been done in certain cases, or even just the research that makes you open up your mind. For example, listening to the issues that women with disabilities face in terms of maternity and maternal care. As LVCT, we do work with people with disability. We've been working especially with the deaf community and some blind, and we've noted those issues in terms of accessing HIV services. So it's also good to expand and see how they affect delivery and pregnancy and how health workers treat them. So it helps to expand my knowledge and scope, and as we deal with policymakers in terms of thinking through how do they change policies or guidelines, we have a broader aspect to think through. And then hearing the other examples from the other countries, research on how governance is, the health governance, how gender plays a role there or seems not to play a role, or how most of our policies talk about gender. Like in Kenya, the constitution is very clear about gender, but the implementation of that is totally lacking. So, and seeing that being unpacked or being brought out from a research perspective, and how we as people who influence policy in different spectrums can actually use some of this evidence to inform that. So if we're thinking about positions, like now we work with the health sector, if we're talking about community health programs, for example, now there's some evidence here that shows that it has to be deliberate to include especially women at all levels, not just at service delivery, but even management levels have to include women. And we have to find a way of fighting the rhetoric that says that you're hired on merit, when we know that if we just put men, we might not understand the issues of women. So if a community health program is full of women, then is it addressing issues of men? And if it's only full of men, or men only come in when they're being paid, and yet we know, especially in our society where now more and more women are becoming breadwinners or at least caretakers, how do we as a program or as research make sure that we defend or protect that position of women and we inform policy in that way? I was also very happy to hear the policymakers speaking and appreciating the role of evidence in informing policy. Like the Kenyan community strategy is coming up, we will be sitting on that table. And now our policymaker is here saying that she's now aware and we're going to be deliberate when we put it. So at least it's not lip service. We know we're going to achieve something because of this meeting. We need to, I know we don't like talking about training all the time, but there needs to be some sort of capacity building for all health planners, programmers, policymakers on what gender, including gender, means, and take it away from that perspective of the men, especially thinking it's all about women. So giving very good concrete examples, and in everything we do, having someone who has that gender lens sitting in those spaces and being clear and addressing those gender norms from the gender issues from what is common in that community, that context. And also, as we do that capacity building, it has to be as simple as possible. It should avoid jargon, give concrete examples, make sure they are contextually appropriate, so that the people who then are involved in these processes can accept the information and use it as they define and come up with these new policies and guidelines. We have to remember, and I liked what was said in the morning, that so when we go to a health setting, we're not looking just at that woman or that man from the person who's come here. We have to look at their culture, their context, where they've come from. So we have to put in their norms, to apply their norms when we're doing their programming. We have to be culturally sensitive. So even if we want to change negative cultural practices, we first have to start by understanding them. We can't just be sitting there high and mighty and declare that this is wrong without knowing where it came from. So when we're dealing with a woman who says she will not seek family planning because her husband will not allow her, we can't just judge her and send her off. We need to be deliberate in finding that partner of hers, bringing him in and using preferably other men who have done it to then reach him with that message. And that has to go across our entire health sector, and it has to be applied in private sector and in public sector, because we've seen these issues cutting across all those sectors, and it has to be also at the community level. This has added to the knowledge I had, which was not too much on gender, but I've been learning more about gender and intersectionality, and will definitely apply it in my work and the work of our organization, and definitely at the policy space when I get a chance.